ADHD assessment, and particularly we'll be talking about best practice ADHD assessments from a neurodiversity-affirming, strengths-inclusive perspective. So it's something that I'm really quite passionate about. It's something that I do a lot in my work in private practice, and I'm very excited to have a chat to you about this. And please feel free to interrupt me at any moment with questions. It's really supposed to help you get out of this webinar what you want to get out of it, set you up to run your own ADHD assessments confidently. So first thing to mention briefly again, especially for those of you that joined a little bit later, is that we'll be recording today's webinar for later viewing. If you don't want your voice to be recorded, you can type your questions in the Zoom chat, in the meeting chat, like everybody has been doing so far. You will get access to the recording of the webinar in the coming week. I will send you the link to that recording. And there are a few people as well who couldn't make it today, but who will be viewing the webinar later on. So let me first tell you a little bit about myself, for the reason that it kind of gives you a little bit of background in terms of why you should take anything I say about ADHD assessment seriously, or why you should consider it. So my name is Joyce. I'm very excited to meet all of you. I'm the founder and owner at Joyce Vromen Psychology, which is a private practice in Brisbane specializing in neurodiversity assessment. So assessments for ADHD, autism, and learning difficulties like dyslexia, dysgraphia, etc. I also provide therapy support, but I really specialize in that assessment part. I previously worked at the Cookie Clinic in Brisbane and Therapy House in Brisbane as well, in private practice, where I did a lot of assessment work as well. They were both great places to learn about ADHD assessment. I learned a lot from Dr. Amelia Shea at Therapy House, as well as Dr. Shannon Morton at the Cookie Clinic. They are also interesting places if you want to learn more about ADHD assessment. You can have a look at both of those places, especially the Cookie Clinic. They're a good place to refer clients to as well, if you would have too many clients for ADHD assessment, for example, because they started a specialist center for ADHD assessment where they have a number of medical doctors working who specialize in ADHD assessment. So that's an interesting place to, keep an eye on. I think it's called The Hive, if I'm not mistaken. Before I worked in private practice, I worked in academic research in the area of psychology and neuroscience. So I previously worked as a postdoctoral research fellow in clinical neuroscience at Oxford University and the John Radcliffe Hospital, where I worked mainly with patients with neurological lesions or neurological conditions like Parkinson's, ADHD, etc. And I mainly looked at kind of attentional processes in these patients and how learning worked in these patients. I also completed a PhD on attention processes at UQ School of Psychology in 2016. And in that PhD, I mainly looked at kind of the early automatic attentional processes and the later more cognitively involved attentional processes. They're often referred to as bottom-up or automatic, and top-down or more controlled attentional kind of control processes. I also completed a master's degree and a bachelor's degree at 2 universities in the Netherlands, University of Amsterdam being one of them. And overall, I have more than 15 years experience in mental health research and private practice across a number of settings. So I've worked in university, hospital, private practice, and also the not-for-profit sector. I'm also a Psychology Today author, and my blog there is called Divergent Minds, and that focuses specifically on the assessment of neurodiversity. So again, including ADHD assessment. So today we'll be talking about quite a number of things during the webinar. So the outline of the slides that I've prepared looks as follows. So first we'll be starting with a bit of basic information. What is ADHD? Probably all of you know what ADHD is, but I think it's important to make sure that we have that common understanding of what it is, how it is currently defined. Then we'll have a look at some of the latest scientific research. So what has been going on in the research world over the last decade or so in terms of ADHD knowledge. Then we'll have a look at why the assessment of ADHD is important. And that's a topic that I'm quite passionate about. I think assessments are really important. I think it's not just about putting people in a box, but I think it can really significantly contribute to people's well-being. After that, we'll talk about best practice guidelines for ADHD. And then we'll dive into neurodiversity, what it is and why it's important for ADHD assessment. We'll talk about strengths inclusive assessment of ADHD and neurodivergence. Then we'll talk about maybe kind of the more exciting part of the webinar, I think, building our own best practice neurodiversity-affirming strengths inclusive ADHD assessment. So this is really where it becomes a bit more practical and really kind of hands-on. Then I'll show you some assessment platforms and tools that I use that will save you quite a lot of time. They automate a lot of the processes of the assessment. Then we'll talk a little bit about how to write high quality, useful assessment reports, and I'll show you some resources that you can find more detailed information about that in. We'll also talk a bit about recommendations following an ADHD assessment and ADHD assessment in women and girls, as well as minorities, because that's still an area that's very much in development, and ADHD is definitely underdiagnosed in women and girls at the moment. Then we'll briefly touch on some conclusions and take-home messages. Again, at any point in time, feel free to interrupt me with questions. More than happy to answer them. Please don't feel like you have to wait until the end to ask any questions. So the first topic is, what is ADHD? So ADHD stands for Attention Deficit Hyperactivity Disorder, as we probably all know. It's a neurodevelopmental condition that affects cognition and behavior. And it often includes signs of restlessness or hyperactivity or impulsivity, as well as trouble concentrating or trouble with attention or trouble with planning. Importantly, the fact that it's a neurodevelopmental condition tells us that symptoms have to be present already in one way or another during childhood. That, however, doesn't mean that ADHD-related behaviors can't change or become more noticeable at later points in time. So what we often see in clinical practice is that some symptoms might have been present very early in development, say before 4 years of age. But often when a child starts primary school, that's when some ADHD-related behaviors become really noticeable and become really prominent. And the reason for that is often that the school environment kind of has different and in some ways higher expectations of a child's behavior compared to childcare or having been at home before that. For example, at school, you need to sit in your chair or sit on the mat for kind of slightly extended periods of time. Other points at which ADHD symptoms often become more noticeable or change is when students start high school, especially the inattentive type of ADHD can become very prominent when starting high school, just because there is more demands on an adolescent's planning skills and ability to schedule different tasks, break big tasks down into smaller goals or smaller tasks. And these are all things that are very difficult with inattentive ADHD. I'm also seeing a lot of adults actually in my private practice for ADHD assessment, and a lot of them have come to see me after they have become parents. So that's another one of those peak moments where people can realize maybe those difficulties that I'm experiencing, maybe they're not part of regular everyday life, and maybe there's something more going on. And generally those environmental things increase the demands that are placed on us. Most people with ADHD are diagnosed currently before age 12 years, but sometimes people are diagnosed later in adolescence or even in adulthood, and that's really quite common, especially with the inattentive type of ADHD. Generally speaking, the symptoms of ADHD improve with age, but many adults who were diagnosed with the condition at a young age continue to experience challenges. So we'll talk about that in a bit more detail later, but the idea that ADHD is a childhood condition, that's really an outdated belief. A very significant portion of people continues to experience difficulties into adolescence, into adulthood. Another thing that's important to keep in mind when you're seeing people with ADHD or starting to diagnose people with ADHD in your practice is that they have an increased likelihood of comorbid conditions like sleep difficulties, mood conditions, or anxiety conditions. So as I already alluded, there are three different types of ADHD, three different presentations of ADHD if you look at the DSM manual. So the first type is hyperactive impulsive presentation of ADHD. And what we often see in terms of behaviors in this presentation is high levels of fidgeting, right? So people who are kind of playing with their clothes, playing with their fingers, maybe with pen, right? Feeling restless, inability to stay in the seat when it's expected in a certain situation, running or climbing at inappropriate times, places, talking excessively, blurting out answers, unable to wait their turn, or frequently interrupting or being intrusive with others. And the critical thing always with ADHD is to keep in mind that in order for someone to meet criteria for an ADHD diagnosis, those behaviors need to be in excess of what would be developmentally expected or developmentally appropriate, right? So with a very young child, you might expect that they are quite restless, right? You might expect that they're not really able to stay seated for extensive periods of time, but it's really when those things are in excess of what we would expect based on their developmental level that we kind of start to get some indicators that ADHD might be at play. The second presentation of ADHD is the inattentive presentation. And this is a presentation that's much more easily missed in clinical practice because it's often less visible on the outside. So with the hyperactive impulsive presentation, that's usually very visible on the outside, right? People are moving a lot, their limbs are moving a lot, they're talking a lot, things like that. But with the attentive presentation, often on the outside, people look quite calm and they might look quite focused potentially. But what we often see is things like people might be making frequent careless errors or overlooking details. They might have difficulty sustaining attention in tasks or activities, and particularly in non-preferred tasks. So one thing that's important to keep in mind is that people with ADHD, sometimes they can pay attention really well, especially for preferred tasks or tasks that they're really interested in. But the difficulty really pops up with non-preferred tasks. So there it's very difficult for them to keep attention on task. And that's not because they're not trying hard enough, but it's really because the brain just functions in a slightly different way. They often might fail to complete tasks or work, have difficulty with organizing tasks or planning tasks. They might easily become distracted. They might be forgetful in daily activities or in conversations. They might frequently lose important or necessary items, and they might avoid tasks that require sustained mental effort. The third presentation of ADHD, according to the DSM, is a combined presentation. So combined hyperactive, inattentive presentation. And there people show signs of both the hyperactivity, impulsivity, as well as the inattention. So if we look at the two most important manuals for diagnosing ADHD, the DSM, the Diagnostic and Statistical Manual, and the ICD, the International Classification of Diseases, we see that there are lots of similarities between both of those diagnostic systems. Both of them, for example, state that the onset of symptoms needs to be in childhood. For the DSM, some symptoms need to have been present before age 12 years. For the ICD, it is some symptoms before age 6, so that puts that bar a little bit earlier. In terms of symptom criteria for children, with the DSM, there are those three presentations that I talked about: hyperactive impulsive presentation of ADHD, inattentive presentation of ADHD, and the combined presentation. For each of those, we need to meet 6 out of 9 symptoms of that particular category. So say to meet the inattentive presentation ADHD diagnostic criteria, we need to show 6 of 9 symptoms of inattention. One thing that's important to point out is that with the combined presentation, we need to observe 6 symptoms of inattention and 6 symptoms of hyperactivity impulsivity. So it's 6 plus 6 for the combined presentation. It's not 6 in total across both categories. For the ICD, there are no different presentations really that are identified. It just says one must have a combination of impaired attention and hyperactivity, impulsivity. And the only subtype that's recognized in the ICD-11 is hyperkinetic conduct disorder. So the ICD refers to ADHD as hyperkinetic disorder. The criteria for adults or people 17 years and over are very similar. The only difference in the DSM is that instead of 6 symptoms out of the 9, we now have a criterion of 5 symptoms out of 9. So there's one less symptom that needs to be met for a diagnosis to apply. For ICD, it's exactly the same as for the child criteria. Another thing that's important is that for a diagnosis of ADHD to apply, several symptoms need to be present in 2 or more settings, and in the assessment settings. Yes, Emily, definitely you will get a copy of the slides. I will make them available. I will let you know how to access them when I send the link out for accessing the webinar recording, but you'll definitely get the webinar recording, you'll get the slides, and you will get that ADHD assessment guide as well. With the settings, it's important to keep in mind that not all symptoms have to be present in all settings. So it's not that restrictive, but we need to be able to see some symptoms in one setting and some symptoms in another setting. They can be the same or they can be different symptoms. When we're looking at kids, the most important settings in their life are the home environment and the school environment, or the childcare environment and the home environment. When we're looking at adults, it's often the home environment, the work environment, maybe social settings, or maybe kind of extracurricular or leisure time activities if they're particularly involved in a specific hobby or specific sports. You can use that as a setting as well. And then the assessment setting, that's another setting. The duration of the symptoms needs to have been at least 6 months. So keep in mind that there's duration and onset, right? So duration needs to have been symptoms need to have been present for 6 months minimum, but some of the symptoms need to have been present during childhood already. And then the other important thing in terms of the diagnostic criteria is that the behaviors or the symptoms that we see interfere with functioning, with daily functioning in one way or another. So they might interfere with social functioning, with academic functioning, or with occupational functioning, or they might cause significant distress. The DSM also identifies 3 severity specifiers. So there's mild, moderate, and severe. The ICD doesn't have those specifiers. Does that make sense so far to you guys? So this is just a brief overview of the diagnostic criteria that are important for ADHD. Are there any questions at the moment? And that's a good question, yeah. So the question is, are there specific symptoms that are a must to have shown in childhood? Not really. There is not one particular type of symptom that must have been present. There's a whole list of symptoms that's listed for each presentation in, for example, the DSM. And as long as it's for children 6 kind of present, or if you're looking back at childhood as an adult, if some have been present, that's enough. We can maybe at the end go into what counts as mild, moderate, and severe. So that's another question. Will we go into what counts as mild, moderate, and severe? I haven't included something explicitly in the slides about that, but let me just make a note of it. And what we can do at the end, if we have time left over, is we can have a look at the DSM and what the DSM says specifically about those severity specifiers. And maybe if we have time, I can show you a simulated client, and we can kind of maybe go over some of the questionnaire results of that simulated client and see whether we would classify them as mild, moderate, or severe, if that's okay. Classifying as mild, moderate, or severe is something that becomes a lot easier once you have seen or kind of assessed quite a number of people. It really becomes a lot easier. Initially, it feels quite difficult, but that's something that with kind of more experience really gets a lot easier. Yeah, so another question is wondering about the overlap with autism. That's a really good question as well. So I won't be talking about that explicitly. I will touch on it in the neurodiversity section, because neurodiversity is really an umbrella term that covers ADHD, autism, and learning difficulties, as well as a bunch of other things. I think one thing to keep in mind is that in people with autism, there is a significantly higher chance that they will have, that they will meet criteria for an ADHD diagnosis as well. Probably our categorical kind of classification, so kind of putting people in the box of ADHD or putting people in the box of autism, is not a good representation of the underlying neurological mechanism. So there's a lot of overlap there. So another question is, are the levels of severity correlated with whether medication is recommended or not? I think that's a really, really relevant question as well. It is. So if we, and we'll touch on that later when we're looking at the best practice ADHD guidelines, where basically according to the latest guideline, the recommendation is when the specifier is mild, first line recommendation would be behavioral support strategies. And only after that, medication support. If the severity specifier is moderate or severe, the first line recommendation would be medication. And kind of then additionally behavioral supports. But we'll come to that again later in the presentation as well in a bit more detail. Great, thanks for all those questions. That's awesome. Okay, let's have a look at the prevalence of ADHD. So how common is ADHD? If we look at the overall prevalence across the lifespan, it's about 5%. So that's really quite significant, right? That's not a small percentage. What that means in very practical terms is that in Australia, there will be about 1.25 million people with ADHD. If we look worldwide, there will be about 400 million people with ADHD worldwide. So it's really a huge number of people. And when we look at neurodevelopmental conditions, ADHD and autism are really the most common ones that we encounter in private practice. So it's not a trivial issue talking about the assessment and the treatment of ADHD. It's something that affects a lot of people. So let's talk a bit about the latest scientific research. So I'm not covering all the research because there's quite a lot of research out there, but I've picked kind of the most important, most interesting topics that I have encountered. If you have any questions about it, about additional scientific research things, I'm very happy to talk about this. This is one of my backgrounds, so I could talk about this probably for 3 hours, but I won't do that today. The first thing that research over the last decade or so really has shown is that ADHD is a lifetime condition for most people. So in kind of earlier times, we used to think of ADHD as a childhood condition, but more recent research really shows that ADHD can be better qualified as a lifetime condition. A significant percentage of people continue to experience ADHD-related difficulties into adulthood. So there's a higher prevalence in childhood. The prevalence in childhood is put at between 5 to 11% of children. Again, this is much higher if you look at particular subgroups. So if you look at kids with autism, for example, that number is a lot higher. But in general, in the population, prevalence of ADHD in childhood is 5 to 11%. Then there's intermediate prevalence in adolescence, so 5 to 7%, research puts that at. And there's a relatively lower, but still significant prevalence in adulthood with 4 to about 6%. One thing that's important to acknowledge is that generally speaking, hyperactivity and impulsivity go down in frequency and in strength as well across the lifespan. So we see a lot of hyperactivity, a lot of impulsivity in very young children, not so much in adolescents or adults anymore. Contrary to that, inattentive behaviors become more frequent and more pronounced as people with ADHD age. So it's well possible that if you kind of initially evaluate a child at, say, 5 years of age, that you see a lot of hyperactive, impulsive symptoms, some inattentive symptoms maybe as well. So let's say we say a combined presentation of ADHD applies in that case. If you now theoretically would see this child again, maybe 20 years later when they're 25, that picture might have changed a bit, and very likely it would have changed so that the hyperactive and impulsive behaviors are less pronounced, they're less noticeable, while inattentive behaviors likely would have increased. There is also some interesting research that shows some evidence of late onset ADHD that has come out over recent years. So what this means is that there's some research that shows that some people don't meet criteria for ADHD in childhood, but then they seem to develop ADHD during adulthood. There's not a whole lot of research on that yet. I don't think that will impact diagnostic criteria, for example, for the foreseeable future. But it's an interesting piece of information that it is much less, I guess, overall a childhood condition than we used to think it is. Another thing that research really shows very clearly is that there's a lot of heterogeneity in ADHD. So when we look at that DSM and ICD formulation that I described earlier, they really conceptualize ADHD as a singular categorical entity with clear and definable boundaries, both between having ADHD and not having ADHD, as well as between ADHD and other conditions, like between ADHD and autism, for example. In reality, that's probably not a realistic representation of how the brain, how the neurology works underlying these conditions. And what we can see is that there's really a lot of overlap between ADHD and other conditions. So if we, for example, look at the causes of ADHD and say the causes of autism at a genetic level, they share 90% of that causality, right? So there's really a lot of overlap. There is a lot of heterogeneity in how ADHD presents. So one person with ADHD might present with very different behaviors, very different symptoms than another person with ADHD. And it's also not as clear-cut, this, I guess, distinction between meeting criteria for ADHD versus not having ADHD. There is a bit of a gray area in between there as well. Some of the recent research suggests that maybe we should identify different ADHD subtypes based on emotional impulsivity and self-regulation ability and temperament profiles. When you look at clinical practice, that kind of makes sense, because one thing that kids with ADHD often struggle with is that emotional regulation and being quite emotionally impulsive. But then that doesn't apply to all kids. So being able to distinguish between potentially different subtypes would be very, very useful. As I already touched on, there's a lot of heterogeneity in causal factors, so we still don't know what exactly causes ADHD. It seems to be a combination of factors, genetic, environmental, etc. But for different people, there seem to be different causes or different genes as well that contribute to developing ADHD. And importantly, there's heterogeneity as well in kind of the experienced difficulties across time, as I mentioned before, right? So when we're in our early teens, our difficulties might look quite different from when we're in our late 30s and just started a family, for example. So ADHD is really a very heterogeneous condition. So let's have a look at some of the brain research then. There has been a lot of neuroscience research in the domain of ADHD over the last couple of years, and we can kind of divide them into 3 levels. So the first level really looks at kind of at brain structure, right? So how does the brain look? How does the actual brain material, how does it look? What that research shows us is that there are not that many differences between an ADHD and a non-ADHD brain. Some differences that we see is that the outer layer of the brain, also called the cortical gray matter, is thinner in children affected by ADHD. It's only a very small difference, not very pronounced. And the second thing is that regions deep in the brain, so the developmentally, like evolutionarily older brain regions, like the amygdala and the hippocampus, they're slower to mature in the ADHD brain. Again, those differences are not very big. So they're very subtle structural brain differences. However, it becomes more interesting when we look at activity within specific brain regions. So now we're really looking at research that's done using fMRI, research that's done using EEG, etc. So it's really not looking at the structural features of the brain, but really those functional activity features of brain regions. What we see there is that brain activity in some regions of the brain is reduced for ADHD. So for example, in the ADHD brain, as a generalization, there is less activity in the frontal control regions of the brain, so in the prefrontal cortex. And the prefrontal cortex is really the control center of our brain. It's involved in cognitive control, inhibition, self-control, attentional control, and also in planning and breaking down tasks into subtasks. The most interesting research falls into a third category, and that's looking at functional connectivity in the brain. So functional connectivity is looking not just at the activity in a specific brain region, but rather how do different brain regions communicate with each other, right? So how does, for example, this prefrontal control center, how does it communicate with the early visual cortex at the back of our head? What we see there is that there are more sizable differences that we can observe. So what we see, for example, is that the brain with ADHD, as a generalization again, shows less communication between prefrontal control regions and the older regions at the back of the brain that process visual input or auditory input. We also see that there's reduced communication between the prefrontal control regions and those older regions of the brain that process emotions, like the amygdala. So this is really a very promising area of research, that functional connectivity. The graph that you see on the right-hand side here, it's a functional connectivity graph. I won't go into too much detail about it. If you are really interested in this, you can look up the paper by Zhao et al. 2022. That's where this graph comes from. Basically, how functional connectivity graphs can be read is that on the outer circle, we see the different brain regions. So at the top right, for example, we see the frontal cortex, right? So brain region at the front of our brain. Then at the left-hand side, we see the temporal cortex. So that's the area of the brain just above our ears. We see the parietal cortex at the bottom left, which is at the top back of our brain and very much involved in attention processes. So a very interesting region as well to look at when we're talking about ADHD. And then we finally see the occipital lobe or cortex at the bottom right, which is at the back of our brain. And that's really the part of our brain that processes incoming visual information, processes incoming auditory information. So question is asked, would these differences show up on a cognitive assessment? So for example, children with ADHD scoring lower on visual spatial skills on the WISC. Yeah, that's a really good question. It would be nice if there would be a particular cognitive kind of profile of strengths and limitations on the WISC or on the ways that would be associated with ADHD, it doesn't really seem to be the case on the individual level. So I have seen, and in general, like when you look at clinical practice, you can observe any type of cognitive profile in people with ADHD. So they might score quite high on visual spatial skills or quite low or anything in between. There's not really that one-to-one correlation. I think the difference in these functional connectivity studies, the difference between these functional connectivity studies and kind of individual assessment sessions is that the studies really average over a large number of participants. So it really kind of allows us to look at kind of the averages, the average ADHD brain, but we're not there yet that we can use it on the individual level. That's something that research is working towards. So ideally, we would be able to use these things in a diagnostic process going forward, but we're not there yet. Okay, then just briefly some outstanding questions that current research is looking at, and that seem quite interesting. The first one is, can we predict patterns of ADHD onset, persistence, and remission? So this is directly relevant for clinical practice, right? If we can somehow predict for which people with ADHD the ADHD will persist into adulthood, and for which people it will cease to be a problem at a certain point in time, that would be very useful, because then we can target our supports, we can target our medication support, for example, to that. Another question that research is looking at is, can we prevent the onset of ADHD through early intervention? So can you, for example, train this prefrontal control region of the brain in such a way that it is more likely to communicate with early visual regions, for example? Another question that we actually know very little about is what happens to ADHD in older adults. So there's quite a bit of research on ADHD in adults, kind of maybe people 30s, 40s, etc. But anything kind of above 50, 60, there's basically no research looking at ADHD in older adults. So it would be very interesting to know what happens on that end of the age spectrum in terms of ADHD symptoms. And another question that research is slowly starting to look a bit more at is, does ADHD come with certain strengths as well? That really fits in neatly with the neurodiversity framework, because that's really the visit strengths balanced approach. It's still very slow, so there's still very little research out there that looks at whether ADHD comes with strengths. But as you can imagine, a lot of the limitations inherent in ADHD in most situations, they could become strengths in other situations, right? So for example, kind of the tendency to rapidly switch tasks, etc., could be very useful in certain work environments, right? Could be the sense of novelty seeking, could be very useful in idea generation, for example. So I think our kind of assessment of ADHD and our view on ADHD has been a bit skewed so far from kind of the medical model. So it's very the physics focused. Well, actually, it makes more sense to look at a balanced deficits strength approach. Does that make sense so far? Are there any questions about that part or about anything else related to research on ADHD so far? Thank you. Thank you. Some positive feedback that it's helpful to discuss these things. Okay, let's jump into why is assessment of ADHD important. This is a section that I'm really excited about. I think assessment of ADHD is hugely important, and I will share with you some reasons why I think it's so important. So there is a lot of research on comparing untreated ADHD. So often in these studies, it's unmedicated ADHD, but often also people who have had an ADHD diagnosis but don't receive any type of support. So no medical support, no psychological supports, etc. And comparing that with treated ADHD. What we see is that people who have received the diagnosis of ADHD but don't receive any supports, they show significant functional impairments. So really receiving that therapy support, and in order to receive that therapy support, you first need to have a diagnosis, makes a huge difference in people's lives. So when ADHD goes undiagnosed or untreated, people on average achieve lower academic achievements. They also struggle much more financially and in employment terms. So they really earn a lower income, for example, as adults. They have higher expenses related to medical expenses, etc. They struggle much more in romantic relationships when someone has ADHD that's undiagnosed or untreated. People with undiagnosed or untreated ADHD struggle much more in peer relationships. They struggle with parenting. They're more likely to struggle with substance or alcohol abuse. They're more likely to engage in criminal activities if it's unmanaged, untreated, compared to people without ADHD and compared to people with managed or treated ADHD. Comorbid mental health conditions go up, so much more common. People with untreated ADHD are involved in accidents and they receive unintentional injuries much more. They even have a higher mortality rate. That's not a huge difference, but there is a bit of an increase in that mortality rate for untreated or undiagnosed ADHD. Generally speaking, they show lowered self-esteem. They show higher or more risky sexual behaviors. And for example, there's increased numbers of teen pregnancies in young girls with untreated or unmanaged ADHD. And they have impacted sleep. So overall, there are so many indicators of reduced life satisfaction and reduced quality of life when ADHD is undiagnosed or untreated. And there's really like a whole host of research that supports that. At the bottom left of the slides, I write down the references that are relevant to the slide that I'm discussing. These articles here, so by Hamed et al. Or by Harpin et al., they're really good reviews of some of these impacts of untreated or undiagnosed ADHD. So when we look at purely financial costs of unmanaged ADHD, they're huge as well. So there has been a really good study that was conducted in 2018 in Australia that looked at the total yearly cost of ADHD in Australia in 2018. And it estimated that it was $12.76 billion. So that's the cost of not diagnosing, not managing ADHD. So that's an amount of money that could be spent on other things if we adequately identify, diagnose, and manage ADHD. The per person cost was estimated to be about $15,000, and the largest component of that was lost productivity. So people with unmanaged ADHD or undiagnosed ADHD, they really suffer a lot in terms of productivity, whether that's at school or in the work environment. They really struggle to do their job as well as people without ADHD, or as people with ADHD that's managed, that's treated. The treatment of ADHD seems to be very cost effective. So diagnosing people with ADHD and then treating them appropriately or providing them with appropriate supports is a lot cheaper than not doing anything. And an interesting and quite sad fact as well is that families of children with ADHD incur the total economic burden over the course of the child's development that was more than 5 times greater compared to youth without ADHD. So it's not only a cost on society, but it's also really a cost on the families, right? And things can be improved a lot by identifying that what's actually going on is ADHD, and then implementing those supports that we know are effective for managing ADHD. Okay, so there are different types of challenges in recognizing and diagnosing ADHD. And they can be kind of divided into parental factors, educator factors, and child factors, as well as healthcare provider factors. So as you might notice, this slide really kind of talks about ADHD assessment and diagnosis in children. For adults, it would look very similar. The healthcare providers would be a variable there. The person themselves would be a variable there. And perhaps employers, but to a lesser degree than educators, play a role for children. So in terms of parental factors, there is often a lot of misinformation as to what ADHD is. So people stereotypically often think of ADHD as the hyperactive, impulsive presentation of ADHD, while people are much less familiar with the inattentive presentation of ADHD. And when a child has inattentive symptoms, they often go unrecognized by parents. They often attribute them to being lazy, not trying hard enough, maybe daydreaming too much. Some other parental factors are openness to medical management, so that differs a lot from family to family. Psychosocial stressors that might be going on at the family level make quite a big impact in terms of whether ADHD will be recognized by parents. And then there are cultural differences that play into that as well. In terms of educational factors, the main difficulty in terms of diagnosing and recognizing ADHD is that there at the moment are insufficient qualified professionals with ADHD knowledge. So some teachers are really good in recognizing ADHD behaviors, but a lot of teachers are not, and they very easily miss behaviors that do fit with a diagnosis of ADHD, and that would mean it would be good to formally assess a child. Same applies to healthcare providers. So at the moment, there are insufficient qualified professionals with ADHD expertise. So then I'm thinking especially about GPs. They're often a first point of contact when parents experience difficulties with their child. They will go and visit their GP. Working in clinical practice, you can really clearly see that difference in expertise, where some GPs are really good. They basically already come to you or refer to you with a provisional diagnosis, while other GPs might just dismiss concerns that parents or adult individuals race when they visit them. Then there's some child factors or adult factors as well, like gender. So ADHD is underdiagnosed in women and girls, for example, much more likely to be accurately diagnosed in boys or men. Race, socioeconomic status, and symptom severity. Are there any questions about that section? Yeah, so someone mentions that they've noticed that GPs tend to refer directly to psychiatrists for the diagnosis. I think often that's correct. I think it does help once people know that you're quite good as a psychologist at assessing and diagnosing ADHD. So my experience is that once a GP has, for example, received an assessment report, and they see that the quality is good, they're quite happy about that. You're completely right that at the moment, the situation with psychiatrists in terms of wait lists is quite terrible. So it's not uncommon to have to wait for a year before you get an appointment with a psychiatrist or a pediatrician as a child. And there can be some financial issues indeed as well. What I usually do is I very openly discuss with clients in their first session that there are different routes of going about getting an ADHD assessment. So I usually tell them, look, you can directly see a pediatrician or a psychiatrist. They can assess for ADHD, or you can see a psychologist, right? You can see me, for example. I can assess and diagnose ADHD as well. The benefit of seeing a psychiatrist or a pediatrician is that they have the ability to prescribe medication, right? That's something I can't do as a psychologist. A benefit of seeing a psychologist for assessment is that usually the assessment can be a little bit more extensive. So there's a bit more room for looking at strengths in addition to limitations. Often, this is not always the case, but often with a psychiatrist, it's the case that it's a very structured interview that really looks at kind of symptoms as observed or described by the DSM, for example, right? So very deficit focused. So I usually kind of, explain to clients that if they come to see me, we have a bit more kind of wiggle space to look at some of those strengths as well. We might, for example, do a cognitive assessment as well, which is not necessary as part of best practice ADHD guidelines, but it can give you more information about someone's individual profile of strengths and limitations. So sometimes I do cognitive assessments as part of ADHD assessment. Yeah, so someone asks, will we be provided with an example? And by the way, I say someone rather than your name, just because the webinar is recorded, and I'm not sure whether you're happy with having your name mentioned. I can obviously see who asks the question. But yeah, I'll just keep it anonymous. So the question is, will we be provided with an example report for someone with an ADHD diagnosis? Yes, you will. So as part of that best practice guide that I will give you access to, there will be an example of a report as well for someone with an ADHD diagnosis. And if we have some time left at the end, we can potentially look at for example, the questionnaires that went into that report. Yeah, so very good question as well is if a client arrives at a psychiatrist with an ADHD formal diagnosis from a psychologist, are they able to accept it and only prescribe medication based on that. And the person in question seems to has seen that some psychiatrists want to do their own diagnosis. I would completely agree. It really depends a bit on the psychiatrist. With most of the clients that I see, the psychiatrist accepts the assessment that I've done. So by far in most of the cases where I see people for an assessment, the psychiatrist will just accept that assessment and have one session with the client where they discuss benefits, downsides of medication, go over some questions again, but that's it. But it is possible with some psychiatrists that they want to do their own assessment. I find when you do quite a thorough report, that chance is a lot less though. So I often make sure that psychiatrists, for example, have access to all of the questionnaire results that we collected as well, in addition to the report. So kind of the more information you can give them about your process, the more likely I think they are to accept that diagnosis. From a best practice guidelines perspective, they should be able to accept a psychologist's diagnosis. They might have to do some little checks before they can prescribe medication, but they shouldn't have to redo the whole assessment. And I honestly think that with most psychiatrists and most pediatricians, if you provide them with enough information, they're quite happy to keep that information gathering stage that they do themselves very, very short, very brief. Okay, let's have a chat about best practice ADHD guidelines. So this is a very important part, I think. It might be a little bit less exciting in the sense that there is a lot of we will be doing quite a bit of looking at the actual guidelines that have been put together. But it's very important information in order to be able to run your own ADHD assessment. So the guideline that we'll be looking at is the most recent ADHD assessment guideline that there is worldwide. So that's the Australian evidence-based clinical practice guideline for attention deficit hyperactivity disorder, and that was released in 2022. And that guideline was really designed to promote accurate and timely identification and diagnosis, and also to provide optimal and consistent treatment. So it's not just an assessment guideline, but it's also a treatment guideline. In total, there are 113 recommendations in this Australian evidence-based clinical practice guideline. And it importantly integrates the best available evidence with multidisciplinary clinical expertise and consumer preferences as well. So what the guideline has done is it has included all the relevant and recent academic research. It has also consulted a whole range of professionals working in the area of ADHD. So that includes psychologists, psychiatrists, pediatricians, etc. But importantly, they also consulted with consumers. So what that means in this case is people who have been diagnosed with ADHD or family members of people diagnosed with ADHD, those that support people with ADHD. So it really has taken into account multiple perspectives. You can access the guideline at www.adhdguideline.aadpa.com.au. And I would recommend that before you start conducting your own ADHD diagnosis, you have a look at the guideline. It has a summary at the beginning, so even if you don't want to read through the entire guideline, the summary points are quite informative. In total, there have been 25 guidelines published for ADHD between 2001 and 2018. But only 3 of them completed evidence-based review searches of research literature in the previous 5 years. So there were only 3 assessment guidelines that queried recent research findings. And the most recent one before the Australian evidence-based clinical practice guideline was the UK National Institute for Health and Care Excellence 2018 guideline, Attention Deficit Hyperactivity Disorder Diagnosis and Management. Then there's also a guideline that was created by the German Association of Scientific Medical Societies that was published in 2017. And then there was a guideline that was published by Kemper and colleagues in 2018. So those 3 assessment guidelines, they are really good other guidelines that you could look at in addition to the Australian evidence-based clinical practice guideline. The Australian evidence-based clinical practice guideline is based on this UK National Institute for Health and Care Excellence guideline. So they're very similar to each other, but the Australian guideline is the more up-to-date one. Okay, so let's have a look at what the guideline actually tells us. What does the most recent guideline tell us about ADHD diagnosis? So the first thing that is mentioned in the guideline is that clinicians conducting diagnostic assessments should be appropriately registered, such as with the Australian Health Practitioner Regulation Agency, APRA. They should be adequately trained in diagnostic assessment using the Diagnostic and Statistical Manual of Mental Disorders or the International Classification of Diseases. They should be experienced with conducting clinical interviews, administering and interpreting standardized rating scales, and assessment of functional impairment. Experience in ADHD diagnostic assessment or undergoing ADHD-specific supervision with an experienced clinician. So those are some recommendations that are put in place to guide clinicians who want to do their own ADHD assessments. I apologize for the quality of this second image that I inserted from the guide. I'll see whether I can update them before I share the slides with you. This is a really important part of the guideline. So this part of the guideline really tells us what should an assessment for diagnosis of ADHD include, right? So what components should we include in our assessment? The guidelines suggest that we should have a full clinical and psychosocial assessment, including discussion about a person's symptoms and strengths and how these present in the different domains and settings of the person's everyday life. A full developmental, mental health, and medical history. So these are things that we generally would cover in an intake interview, right? So if you do a very thorough, quite structured intake interview, you would be covering most of these things. An additional thing that should be included is self and observer reports and assessment of the person's symptoms and mental state. So often the easiest way to cover this is by including some questionnaire measures that we ask the participant themselves to complete, if they're old enough to do that, but we also ask somebody else to complete those questionnaires so that we have that observer report as well. And then a third kind of component that's not always necessary, but that's necessary in some cases, is a medical assessment to exclude other causes of the symptoms and identify any associated disorders that also require investigation, intervention, and support. So medical investigations should only be performed if clinically indicated. So for a standard ADHD diagnosis, if there's no indication of any medical difficulties, or for example, any hearing difficulties or any vision impairment, that's not required, right? So basically what the guideline suggests is we really need a very good intake interview, very thorough intake interview, and then we need some observer and self-reports that assess the person's symptoms and mental state. So that would generally be an ADHD-specific questionnaire to assess their symptoms, and to assess their mental state, a more general psychological questionnaire to screen for a whole host of difficulties and look at their strengths as well. Okay, so someone mentions intake interview is a new phrase. Okay, psychologist from the UK. You just moved here. That's great. That's awesome. I'm actually thinking from my time in the UK, I actually don't remember how we used to refer to an intake interview. What I mean by an intake interview is just the first session that you have, where usually you gather some information from your clients, right? So what is, for example, the reason that they're presenting at this point in time? What difficulties have brought them here? How has this difficulty kind of developed throughout time? So usually kind of refers to the first session. When you run assessments, you tend to collect quite a bit more information from people compared to when you're seeing people for therapy support. At least that's, in my experience, the case. Someone asks, what would be a broad questionnaire to better understand the mental state of the client if they are a child or adolescent? There are quite a few different options, and I'll show them to you later. One particular questionnaire that I really like to use is the Conners Comprehensive Behavior Rating Scale, or the Conners CBRS. Don't be fooled by the name Conners. That's often related to ADHD, right? But the Conners CBRS really screens for a whole range of difficulties. So it looks at ADHD, autism, anxiety-related difficulties, mood-related difficulties, conduct-related difficulties, academic difficulties. Really screens for a whole range of potential difficulties or strengths. But I'll touch on that a bit more later on. So let's have a look at this slide here. So in an assessment for a diagnosis of ADHD, a clinician should assess symptoms and signs of hyperactivity, impulsivity, and/or inattention, and ensure all the following apply. So very understandably, symptoms must meet the diagnostic criteria in the DSM or ICD. Importantly, symptoms cause clinically significant psychological, social, or educational or occupational impairment based on interview, questionnaire, or direct observation in multiple settings. I'm not sure why they mentioned this separately, because that's already part of the DSM and ICD diagnostic criteria. So that would already be part of that first point over here. But that's very important. So if someone presents with ADHD-like symptoms or behaviors, but they don't actually have any impact, any negative impact on their life in any area whatsoever, we can't diagnose them with ADHD. So they might be super hyperactive, but if it really doesn't have any negative impact on their life, according to the diagnostic criteria and best practice guidelines, we just can't diagnose them with ADHD. Now, that's not often the case, that there's really no impact. Often when you dig a little deeper, even if people initially say, no, it doesn't impact me that negatively, you can still see impacts. So for example, what you often see is that with kids, when they're cognitively quite bright, cognitively quite able, right? So they have a relatively high cognitive score. If you do the WISC or the WAIS, you will see that even if they have quite strong ADHD symptoms in primary school, they often get relatively good grades just because they're there in class, they take in some information, and because they're so cognitively able, they just get passing grades. Sometimes people say, oh, but then if kids have passing grades, they can't have ADHD. That's not the case. But in those cases, you might have to look a bit more carefully to find what are those impacts then, right? And it might be that they're underperforming compared to cognitive ability, for example. Symptoms are pervasive, occurring in 2 or more important settings, including social, familial, educational, and or occupational settings. Again, yes, that's part of the diagnostic criteria. Importantly, symptoms are assessed in the context of the person's age, developmental level, and intellectual ability. So that's really important. Always keep in mind that we would expect more higher levels of activity and impulsivity of younger children, for example, compared to older children or adults. And that's developmentally completely appropriate. So always compare behaviors to what's the developmental age of the person. So they also recommend including an assessment of the person's needs, functional impairments, participation, and quality of life. So that's something that I often see is missing in people's ADHD assessment. So that assessment of the person's needs and functional impairments. There's some easy ways, though, to do that, and we'll touch on them later again. But one option for this, to meet this, this criteria, is to include an adaptive functioning questionnaire in your assessment, like, for example, the ABAS, that really looks at functional impairment level of adaptive functioning. So it's really quite simple to meet that recommendation. Include an assessment of possible differential conditions or co-occurring physical and mental health neurodevelopmental disorders, social, familial, and educational or occupational circumstances, and physical health. So basically what this recommendation tells us is don't zoom in too specifically from the start on ADHD and kind of have blinders for anything else that might be going on. Often what I recommend doing is starting off a little bit broader, right? So kind of starting off with the idea that, okay, we're assessing for ADHD, but we don't want to forget about other things, right? We also want to keep an eye on mood difficulties, for example, or anxiety-related difficulties, or things that might be going on in the family environment, like trauma or things like that. So kind of make sure you don't lose track of those other things that might be going on, whether they're things that occur together with ADHD, or whether they're things that might be an explanation for the observed behaviors as an alternative to ADHD. Include an assessment of the person's strengths and factors the person may have identified that minimize symptoms of their impact. So I think this is quite an exciting recommendation that's included in this most recent international guideline. So it really suggests us to look at a person's strengths as well. Now, the guideline doesn't give very good advice for how to do that, but at least they mention it. So I think that's something that kind of is important to keep in mind, like how can we assess people's strengths as well? And we'll talk about that in a lot more detail later on. For children and adolescents, inquire about family functioning and parents or carers' mental health to enable provision of support for parents, carers at the time of diagnosis. So if you're working with a child, you're never working only with the child, right? You're always working with the family as well, to one degree or another. So kind of, if you're working with child clients, get some information on the family, get some information on the parents as well, so that you can target your report to their level of understanding and to their level of functioning, so that they can make optimal use of it. Some cautionary points that are included in this most recent evidence-based clinical practice guideline is that a diagnosis of ADHD should not be made solely based on rating scales or observational data. They're very useful components of an ADHD assessment, but they shouldn't be the only components that we rely on. Observations from more than one setting and reporter should be used to confirm if symptoms, function, and participation difficulties occur in more than one setting. So that's really important, I think, that we always want to have multi-setting or multi-reporter information. So there's a question that asks, apart from during childhood, are there specific stages of life when previously undiagnosed ADHD symptoms might become more obvious? Yep. For example, during the transition to parenthood, or when starting a new job, or during tertiary study. Yeah, those examples are really spot on. So what I see a lot in clinical practice at the moment is that a lot of my adult clients come in after they have become parents. So that's really one kind of peak moment where more people realize that maybe I do kind of meet criteria for a diagnosis of ADHD, or at least it's worth looking into it when there's another person, like a baby, that comes into the picture, just because it increases the demands on your executive functioning, on your attention, on your kind of management skills, right? Because now you not only have to manage your own agenda or calendar, but you also have to manage that of another human being. So just that increased level of demands that often makes people come in to get an assessment for previously undiagnosed ADHD. Changing a job is another very kind of prominent example, often kind of advancing in one's career especially, can be a point where ADHD kind of questions arise or pop up again. Often when people are promoted to more managerial roles, that's often a point where they wonder, maybe I do have ADHD, because often people kind of find some strategies to manage this in their own work, but then when they have to start working with others, they can't often they can't use those same strategies to the same degree anymore. Sometimes getting into a new relationship or getting into a first relationship can really be one of those prompts for having an ADHD assessment done. Yeah, so there are really quite a few specific life events or stages that often prompt adults or adolescents to come and seek an ADHD assessment. Yeah, by far the most prominent one that I see in my practice is starting a family, so having kids. So another part of the clinical practice guideline is that clinicians should consider the different presentations of ADHD and the fact that many children and adults may not present with the most visible symptoms of hyperactivity and impulsivity. So this is really cautioning us that kind of be careful not to overlook, especially that inattentive presentation of ADHD. And from working in clinical practice, the hyperactive impulsive presentation of ADHD is really quite easy to diagnose. Often the different raters, so for example, parents, the child themselves, if they're a bit older, or the adult themselves, if they're adults already, and kind of significant others like a teacher or a partner, they all notice these hyperactive impulsive behaviors. It gets a lot more tricky when it's the inattentive presentation of ADHD. Clinicians should be aware that inattentive symptoms may not be identified until secondary school or later, following increased demands for organization and independent study or work. So that's something I see quite often, that people with inattentive ADHD come in for diagnosis once they're in high school. Often they do reasonably well in primary school, but then once they're in high school, they really start struggling. Clinicians should also be aware that people may have developed compensation strategies that may mask symptoms. So masking is not only a thing in autism, masking is also a thing in ADHD. Often, especially again, people who are cognitively quite able, they come up with quite elaborate, quite sensible strategies that work quite well. And that can make the symptoms seem less severe to outsiders, while actually internally people often feel very overwhelmed or very exhausted by constantly having to employ those strategies. So that's actually, I think, one thing that's really important to ask people about as well when you're talking to them is, how does it feel to them, right? So can they organize things, or can they keep track of things easily, or does it feel really effortful? If they can keep track of it, how do they do it? Like often I find out that people with inattentive ADHD, they say, yeah, actually I can remember things quite well, and I can organize things well. And if you kind of ask a bit more, they say, well, yeah, I do have 20 reminders on my phone, because otherwise it doesn't work, right? So often they develop quite good, but quite tiring methods of coping with these difficulties. Very important, the views of people with ADHD, including children and adolescents, should be considered when determining the importance of their symptoms and limitations. So really that client-led, client-centered perspective, right? So we really want to do the assessment with the client who comes to us, not for or to the client, right? I always present this as, this is a collaborative process, right? We are starting a dialogue. I have the knowledge of how we do an assessment, but we need your input as the client, and that's at least as important. With questionnaires, I definitely always ask adults to complete a questionnaire themselves, adolescents also. With children, usually from the age of 10 years old, I also ask them whether they want to fill in a self-report questionnaire. When they're younger, they're often a bit more hesitant. I sometimes do propose it, but then they obviously have a choice whether they want to do it or not. So there's a question that asks, is there a difference of impulsivity, hyperactivity symptoms presentation in adults, and how impulsivity, hyperactivity presents in adults? There is a little bit. I think for me, the most noticeable thing is that hyperactivity, impulsivity in adults often is related to talking or speaking more so than kind of other ways of acting out. So I find that with a lot of adults who meet hyperactive impulsive presentation of ADHD, they talk a lot, and they talk about a lot of different topics in a very short period of time. They struggle to wait for their turn in conversations. They often show some other signs as well, but I think really that verbal aspect becomes really pronounced in adulthood. Okay, so someone asks, do clients fill in these questionnaires on their own time or in the office? So with how I run the assessments, they fill them out in their own time. So I'll later show you some platforms that I use for distributing, scoring, administering those questionnaires. So I basically send people a link, they click on the link at home and complete these questionnaires in their own time. That 99% of the time that works absolutely fine. People in a way prefer it because then it doesn't take up their session, for which they have to pay kind of my fee. They just pay the questionnaire kind of cost instead. The only reason I would see for completing questionnaires in session is if you have a client who struggles cognitively, or a client who might majorly struggle with reading or writing, for example, or maybe if you have someone from a culturally kind of diverse background who's not very kind of proficient in English or whatever the language is in which you administer the questionnaire. I think in those cases, it makes sense to do it in session. But generally speaking, really for 99% of the clients, it works really well to have them fill out the questionnaires in their own time. And then we discuss them later on. What do we find in the questionnaires? Okay, I won't read through all of these points. Basically, the summary of this slide is that there are information needs as well after the diagnosis of ADHD, right? So we don't just do the assessment, say, okay, you meet criteria for an ADHD diagnosis, that's it. But instead, we need to provide people with some information sources, some resources that they can go to learn more about their diagnosis, or to connect with others who have received a similar diagnosis. That helps them understand their symptoms of ADHD and why they are in line with ADHD. Yeah, so kind of keep in mind that even though what we focus on is doing the assessment, doing the diagnosis, there are some responsibilities that we have as well, kind of after that assessment kind of ends, right? So kind of in terms of providing people with a report, we need to make sure that we provide them with sufficient information for them to move forward. And on this slide, there are just some examples of those things that you can include. So, for example, local and national support groups, voluntary organizations, reputable websites, whether they're eligible for government benefits or allowances, etc. Unfortunately, in Australia, I don't know how it works in the UK or in the US, unfortunately, but in Australia, ADHD diagnosis by itself generally doesn't give people access to, for example, NDIS funding. Yeah, and always make sure that, I guess, we provide the information in a way that's tailored to the client's needs, right? So, for example, if you have a client with a relatively lower cognitive ability, make sure that the report is put in such a form, into words, in a way that they can actually take it in. They might, for example, also want to have a support person present, things like that. So make sure that you keep your audience in mind when writing an assessment report. It's not meant for us, but it's really meant for the clients to understand themselves better and to understand what are the next steps that they can take. Yeah, so someone asked, will there be a short break soon? I think that's actually a great idea. Maybe when we get to the end of this section, I think it would be good if we have a short, maybe 5-minute break so everybody can stretch their legs, maybe top up their water or tea. Would that work for everyone, or is there anyone who has any kind of issues with having a short break? Okay, seems like everybody is okay with that. So let's just kind of make it through the next few minutes. What time will we finish today? So we will finish latest by 1 p.m. We might finish a bit earlier. It really depends on how many questions there are and whether we still want to have a look at, for example, some of those questionnaires with kind of a simulated client. We definitely won't go over time, so we'll be finished by 1 p.m. These are just some recommendations on here in terms of report writing. So just some practical suggestions that more manageable chunks of information are easier to remember. Visual aids or pictures are useful. During the feedback session with the clients, where you discuss the diagnosis and their individual profile of strengths and limitations, encourage questions, etc., etc. One thing that's important, I think, to point out briefly is that one of the recommended supports for children with moderate or severe level ADHD diagnosis is parent training. Now, the parent training, I think it's important to mention in the feedback kind of session with the family that the parent training does not mean that the parent is not doing a good job. Parent training is simply meant to help the parents cope with the additional demands that parenting a child with quite strong ADHD symptoms brings with it. So it's just a support. It's absolutely not an indication that they're not doing a good enough job or that they are playing any role in the ADHD behaviors that the child displays. Another thing to discuss in the feedback session, according to this guideline, and I think that makes sense, is whether the client wants to share the report with anybody else in their support network. So generally, I suggest people to consider whether they want to share the report with their GP, because they're often kind of the center of the communication hub. So having them in the known is often very useful. If they have already have a pediatrician or a psychiatrist, would be sensible to share that with them. If they have any other type of support people, makes sense to share it with them as well. However, it's always the client's choice, right? So kind of just a very brief summary before we take our break of what we need for a best practice ADHD guideline. That's a detailed, thorough interview with our client, right? That covers their general mental health and well-being, that covers ADHD-related symptoms, but it also covers a bit about kind of their family situation, etc. So kind of some general medical background as well, general mental health background, and kind of how symptoms have developed throughout time. A second thing that we need is multi-informant questionnaire measures, ideally a broadband questionnaire that screens for a whole host of difficulties and strengths, and then a very specific questionnaire that really zooms in on ADHD. Ideally, we also include some strengths-based measures. That's what the best practice guideline also recommends, right? And we provide information to clients in their report and in the form of a feedback session so that they can educate themselves and take the next steps in their ADHD journey. So we really want to set them up for taking the next steps in their journey rather than just giving them a diagnosis. We want to help them along. Okay, let's have a 5-minute break. It's 11:50 now, so maybe around 11:55-ish, we start up again. Yeah, stretch your legs, give yourself a rest, and I'll speak to you soon again. Great. So if it works for you guys, we'll continue with the rest of the webinar. Could I just ask you again whether you can hear and see me again? Oh, that's great. Thanks, guys. So let's start with talking a bit about neurodiversity. So this is a topic that I'm quite excited about. And we'll talk a bit about what it is and why is it important for ADHD assessment. So neurodiversity is really a very different approach to thinking about mental health than the medical model approach that the DSM and the ICD are based on. So our current thinking is still very much influenced by the medical model, so conceptualizing cognitive differences in terms of disability or disease. Autism spectrum disorder and attention deficit hyperactivity disorder, ADHD, for example, derive from a disability-focused view, right? So in many ways, our current thinking still focuses primarily on the visits and those behaviors and cognitions that people with autism or ADHD or another diagnosis can't perform as well as individuals without such a diagnosis. Now, those things are important, right? But the question is that the whole picture, or is there maybe another view that we can have? So contrary to this disability-focused view, neurodiversity is a concept that views differences in behavior and cognition as normal variations in a population rather than disorders per se. So the definition of neurodiversity has widened across the last decade or decades, and now encompasses a range of cognitive differences, including but not limited to autism, ADHD, dyslexia, and dysgraphia. So the neurodiversity movement really relies on a strengths-based or strengths-inclusive, I think is more accurate model, instead of a model of this deficit. And there's quite a lot of overlap between other kind of equality movements, like, for example, the women's rights movement, Black Lives Matter movement, etc. So really, neurodiversity is the idea that being neurodivergent, right? So falling within that category of ADHD, for example, doesn't mean that we have a disorder per se. It just means that we show we fall on the further end of that normal variation in the population. And that comes with limitations, but that also comes with strengths. So it's kind of a balanced strengths limitations approach. Some examples of neurodiversity affirming practices can be things like talking about differences rather than the visits and validating differences, right? So when we're, for example, talking in a feedback session to someone with ADHD, rather than saying you have a deficit in paying attention, right? We can say you fall at this right-hand side end of the attention spectrum, right? It's a bit different from how someone who is neurotypical presents. It's not necessarily a deficit, but it's different, and it can cause difficulties in certain situations. Another neurodiversity affirming practice is to frame differences as fluid rather than fixed, but that they can benefit from support or coaching. So rather than talking about therapy or fixing the visits, we talk about coaching or support. We talk about limitations and strengths. We don't use words like disorder. We use respectful inquiry. So really checking in with people. How does it feel for you? How do you experience this? we try to understand different perspectives. So this is really important, especially with autism, maybe a little bit less so with ADHD, but it's still quite critical, kind of trying to understand what perspective are your clients coming from. Very important to have conversations about client preferences, for example, in terms of language. So are they happy to use ADHD? Do they want to use neurodiversity? Do they want to be addressed as a person with ADHD or as an ADHD person? People have different preferences about that. So really kind of in the neurodiversity framework, we see that interaction as a two-way street. So rather than us being the health professionals that talk to the client to give them information, it's really a two-way conversation. That emphasizes personal agency and safety as well. And in the kind of assessment setting, but also in the subsequent therapy setting, we always try to accommodate individuals' needs, right? So different sensory needs, different kind of outwardly different looking listening skills. So often people with ADHD, they will need to be doing something else while they're paying attention. So they might be fidgeting, or they might be looking away, might be looking at lots of different things. But that doesn't mean they're not paying attention, even though for a neurotypical person, that would mean that they're unlikely to be paying attention. For neurodivergent people, that might actually look very different. And I guess ultimately what we want to contribute to is assisting in developing self-advocacy and kind of those problem-solving skills so that people can advocate for themselves. I just see that there's a question as well. So someone asks, am I taking referrals for ADHD assessments? Yes, I am. I do indeed see people through telehealth as well. And yes, I'm also offering supervision in the area of ADHD and autism assessments. I'll touch on that a little bit later as well. So let's have a look at what a strength-inclusive assessment of neurodivergence and ADHD, what that would entail. So currently we have a deficits focus, right? DSM and ICD are deficits focused. The current guidelines don't provide much guidance on strengths inclusive assessment. So that most recent international Australian, but kind of that can be applied internationally, guideline does suggest we include some information on clients' strengths, but it doesn't guide us in how to do that. But we really want to incorporate neurodiversity and strengths-based principles in assessment, so it can be an affirming, positive experience. So people often come to me and they say, actually, I had an ADHD assessment done previously somewhere, and now I'm coming to see you for therapy. But the assessment experience was very demotivating and it was very confronting. And I really feel like I'm not good at anything after going through that assessment. So that's really something we want to prevent in our best practice strengths inclusive assessment process, right? We want to make it a positive experience for people, kind of an empowering experience where they increase their self-knowledge, right? They learn more about those things they're good at, as well as those things that are more difficult for them than for other people. But we want to give them hope as well, right? We want to share some of those strengths with them. And I think kind of looking at recent research, we see that kind of receiving a diagnosis by itself is beneficial for clients' levels of well-being and self-esteem. So just having that understanding that, no, it's not because I'm not trying hard enough, but there's really kind of an objective reason why some things are harder for me to do. That helps with their well-being, helps with their self-esteem. But I think if we can kind of change our assessment processes in such a way that they're strengths inclusive, I would expect that that benefit would be even larger. And I think that's a good thing to aim for. So let's pause for a minute and look at what are some ADHD strengths. So I actually had to look quite hard to find these in the literature. I think it's not because they are not there, but it's just because we don't focus on them, right? ADHD strengths can be high levels of energy, right? Rather than hyperactivity, which it is in certain situations. In other situations, that might be high levels of energy, which might be good for task completion, right? In certain high stress, high performance jobs, for example, where there is a lot of stress, a lot of pressure, and where you kind of need to have high levels of energy. Hyper focus, so that's often the kind of flip side of the difficulties with focusing on non-preferred tasks. People with ADHD can often show hyper focus or really good focus on tasks that they're particularly interested in. So that can be a benefit as well. Research shows that people with ADHD show higher levels of creativity, both in terms of verbal tests of creativity, so idea generation, for example, but also more traditional views of creativity. They score higher on divergent thinking and generating multiple solutions to a problem. They show higher novelty seeking, which in some situations can lead to problems, right? If you think about it in the domain of drug and alcohol abuse, for example, right? Higher novelty seeking might make you more likely to become a user of alcohol or other drugs. But in many other situations, it can be a benefit as well, novelty seeking. In certain work environments, this can be really good, really beneficial. They show higher ability to make rapid decisions under pressure. They show higher levels of resilience. They show a better ability to engage in multitasking. They often show really good big picture thinking as opposed to paying attention to details, which is often more difficult for people with ADHD. And they can often be very cool in a crisis. So kind of high pressure jobs might work quite well for certain people with ADHD. And then there are also ADHD, kind of non-ADHD specific strengths that you could look at as part of the assessment process. So you could, for example, look at, does a person have particular cognitive strengths, right? Or do they have particular strengths in adaptive functioning? So these are not unique or kind of necessarily directly related to the fact that they might also qualify for an ADHD diagnosis, but it can help, for example, with formulating recommendations on how to deal with some of those difficulties that present as part of the ADHD picture, right? So for example, if you do a cognitive assessment with someone as part of their ADHD assessment and find that they have particularly good visual working memory, right? That might be something that's very valuable in kind of helping them pay better attention in the school environment, right? So for example, presenting them with visual information in addition to auditory information might well increase their ability to pay attention. So it's definitely not the case that we have to stick with these ADHD specific strengths. We can also look at strengths more widely speaking as part of our assessment. But the general thing is that we kind of want to widen our focus, not just zoom in on the things that are difficult, on the things that are more problematic, but also get an understanding of which things this person is really good at. So are there any questions about neurodiversity so far? I included some links as well if you want to do some further reading in the domain of neurodiversity. Do you ever only test for ADHD in isolation is a question. I would never test for ADHD in isolation if what you mean is doing so without having, for example, a broadband assessment questionnaire as well that screens for a whole array of things. I probably wouldn't. It's also not in line with best practice guidelines. So part of the best practice guidelines is the recommendation that we look at co-occurring conditions or kind of alternative conditions that could explain the same symptoms. If you really only focus on ADHD without having any measure at all of anything else that might be going on, you can't really do that. But I think you can do it in a very, very succinct, kind of straightforward way. If you already have one questionnaire that's more broad in its focus, I think that already gives you sufficient minimal information in your ADHD assessment of other things that might be popping up. But I would generally advise go into an ADHD assessment with the goal of looking at ADHD, but not excluding other things yet. Because it is the case that sometimes some other things, like, for example, learning difficulties, they can present in a way that's quite similar behaviorally to ADHD. So there are other explanations that might explain some of the ADHD, supposedly ADHD-like behaviors. Okay, so let's talk a little bit about the clinical interview, or what I previously referred to as that intake interview. There are a few options there. So one option is to use a semi-structured ADHD interview, like the DIVA, that's for adult ADHD assessment, or the NCSR revised, which has an adult and a child version. So these are semi-structured ADHD interviews that are specifically designed for assessing for ADHD symptoms, but also taking a general history, etc. There are also paid alternatives to these two examples that I gave, the DIVA and the NCS. If you look at Pearson, for example, Pearson website. You could also consider using a more general semi-structured interview like the DISC or the SCIT. Especially if you're not sure what you're looking at initially, like you might not kind of start out with looking at ADHD, but you might, I don't know, start out looking at, you might not know kind of initially what might be going on. Then a more general semi-structured interview or structured interview would make sense. In the clinical interview, you need to gather ADHD specific and more broad mental health information. So I guess that ties in with that previous question of, do you ever test only for ADHD in isolation? You don't really do that generally. You do spend a much larger proportion of the time covering those ADHD-like behaviors and related things than you do other potential explanations, but I would always include some of that kind of more general screening. An alternative to using these interviews is to take a more client-led approach. And that's something I do quite often. So I just ask clients, well, what has brought you here at this particular point in time, right? And then we start from there and we just have a bit more of a flowing conversation. That's a lot easier if you're familiar with, for example, the DIVA or the NCS questions, because then you can just kind of slot those questions in while you're talking and while it is a bit more client-led. So the last option is my preference generally, to have a more client-led approach, but ask questions that come from the DIVA or the NCS or another instrument like that. I think it's important in the clinical interview as a psychologist to balance rapport building, information gathering, and listening skills, right? So you're doing all of those things at the same time. Often it's a little bit more difficult to build rapport if you use a structured or semi-structured interview. All of these are good options, right? So this is one thing that we need in a good assessment, best practice assessment process, a clinical or intake interview. Then the second thing that we need is multi-informant questionnaires. So like I said before, we need multiple questionnaires, right? We need ADHD specific questionnaires, and we need a general broadband questionnaire, and we need an adaptive functioning questionnaire potentially, unless you covered that already in your clinical interview, and then you could get away with not doing the adaptive functioning questionnaire. So ADHD specific questionnaire and a general broadband questionnaire is needed. We also need multiple informants, right, in line with the best practice guidelines. So in children in primary school, usually I will ask parents and teachers to complete the questionnaires. Sometimes I'll ask the child themselves as well. Most of the time in primary school, they're kind of likely to say no, but ask them, especially if they're in the kind of older years of primary school. Adolescents in high school, I generally ask for self-report questionnaires, parent report questionnaires, and teacher report questionnaires. It can be a bit more difficult to select a teacher in high school because kids spend less time with one teacher in particular, but most of the time we can work out a teacher whom the child is happy to ask or the adolescent is happy to ask and who knows them reasonably well. With adults, I generally ask for a self-report questionnaire and a questionnaire completed by a close other. So that can be a partner, can be a parent, a friend, can even be an adult child. So just someone who knows the client quite well. The reason for having multiple informants is that often things can look quite different from the outside than that they feel from the inside. So, for example, with inattentive ADHD, often this feels much more kind of strongly on the inside, so in the self report questionnaires compared to the other report questionnaires. For hyperactive impulsive ADHD, it can be the other way around. So there's really added benefit also if you look at the research, look at the best practice guidelines to have multiple informants. Then let me actually just go into a little bit more detail about the specific questionnaire. So examples of ADHD specific questionnaires are, for example, the Conners, the SNAP, the ASRS, and the CARS. Those are really good questionnaires to use. Then there is general broadband questionnaires like the Conners CBRS, the Conners Comprehensive Behavior Rating Scales, and questionnaires like the CBCL or the BASC. What I actually often do in my assessment process is that I don't use a separate ADHD specific questionnaire and a specific broadband questionnaire, but I often use the Conners CBRS to fulfill both of those functions. So it's still a Conners function in that it assesses ADHD in quite a lot of detail, but it also screens for a whole host of other things, like I mentioned earlier in the talk. So that can be quite efficient. Yeah, so question is, are these examples of the best measures? How do you make a decision on which one is more appropriate for the specific client? These are examples of the best practice assessment instruments that I would recommend using. Definitely for ADHD, all of the Conners questionnaires are pretty good. For adults, the CARS is very, very suitable. Yeah, Connor CBRS is very good as well. How do you make a decision on which one is more appropriate for the specific client? So I, generally speaking, only use different questionnaires based on age. So for children, I generally use the Connors CBRS. For adults, I usually use the CARS. It might be a bit different if you work a lot with populations where they might have cognitive impairments, etc. So that would be kind of slightly different, and you might make a different decision there. I'm happy to talk about that individually. But I think, generally speaking, I would suggest settle on one adult questionnaire, settle on one child questionnaire, and use those as your go-to questionnaires. So don't look too much at the kind of individual client characteristics. They all cover quite a wide range of ADHD-like behaviors. So they work quite well for a lot of different clients. Potentially adaptive functioning questionnaires. You can think of questionnaires like the ABBAS or the Vineland. Okay, so adult assessment. So for adult assessment, I would really use the CARS. That's the Connors Adult ADHD Rating Scales. They're very well validated. They're used a lot. Yeah, so I would really, it's not the only option, but I would really recommend using the CARS. That captures hyperactive impulsive ADHD, also captures inattentive ADHD, and that has some very good subscales in there that you can look at. So for adult, so another question is, can I use the Connors CBRS for adults and children, or just CARS for adults? So the Connors CBRS is not for use in adults. So I think the upper age limit, I have to check, it's either 16 or 19 years of age. So the Connors CBRS is really for children and adolescents. The CARS is for adults. Because the CARS is an ADHD specific questionnaire, I would always use that together with a general broadband questionnaire. So I often use the SEL as a broadband questionnaire with the CARS. There are many other broadband questionnaires that you can use. I just use the SEL because it's easily kind of accessible online. Yeah, so another good question is that, do I ask people generally do I generally ask people to complete the questionnaires before or after the intake interview? There has been a lot of discussion about that. There are benefits and kind of disadvantages to either option. I generally first have the intake interview. So I first have the intake interview, and then based on that intake interview, I decide, can I go for my usual go-to questionnaires, or do we need to add anything or subtract anything if they already have had some questionnaires completed, for example. So my preference is definitely to do the questionnaires following the intake session. So the general questionnaire I use, like the Broadman questionnaire for adults, is the one that I typed in the window above. It's the SCL 90R. I think it stands for symptom checklist. So symptom checklist 90 revised. There are many other options there though as well. So that's just the option I use. Okay, let's have a chat about strengths-based measures that we can use. So strengths-based measures are a bit more difficult to implement in the sense that they're not as easily accessible as some of the more traditional measures that I mentioned on this page, for example, the Connors, the Abbess, the CARS. I'll show you some easy ways to access them later on. Strengths-based measures are a bit harder to access, so you might have to do a bit more digging to actually find them. Some options are using a character strength measure. So for example, the JTCI for children or the TCI for adults. You could consider using the VIA or the GRIT survey. You could consider using the brief strengths test. I've added links to this slide. So when I send you the slides, if you click on them, this will take you to the location where you can either find these questionnaires or it takes you to an article that is related to the design of the questionnaire. Some other recommended areas to look at are self-determination for ADHD. So you could look at something like the SDSS or the SDS or the AIRS. Another area that neurodiversity research suggests you could look at is creativity or divergent thinking. So there's the TTCT or the ETA or the CAQ or foresight. So these are all really good options. I wouldn't recommend doing all of them. I would just recommend choose one or maybe two and kind of include those as your strengths-based measures. As I already said before, none of these questionnaires are available through the centralized assessment platforms like Pearson. So it is a bit more frustrating to find them, to access them. So you might have to be a bit pragmatic there or a bit practical as well there and just kind of settle for some of these that you can actually access, while others might be, like, for example, the AIRS, that's quite easy to access. But I think, if I'm not mistaken, the SDSS, I haven't been able to access that one. Another option is that you can include other tasks or other assessments that are not ADHD related to look at individual profiles of strengths and limitations. So I, for example, often do the WISC or the WAIS as part of an ADHD assessment. Now, based on best practice recommendations, it's absolutely not necessary to do a cognitive assessment like the WISC or the WAIS. You don't need to do that for an ADHD assessment. But I often discuss with people, do you want to learn a bit more about kind of your cognitive profile of strengths as well as part of this ADHD assessment? Or are you interested solely in getting the diagnosis and the recommendations going forward from there? If you do a WISC or a WAIS, you can kind of give people information about their verbal ability, about their general cognitive ability, about their fluid reasoning, etc. And these are all things you can use in the recommendations of your ADHD assessment report. So I'll just briefly show you 3 platforms that I often use for administering my ADHD questionnaires. I think they're absolutely great. It saves you the time of like printing or hand scoring assessments. You do pay a fee for each of the assessments that you have the system analyze, but it saves you a lot of time and kind of overall in terms of cost benefit analysis. Yeah, you would be able to earn much more money kind of in the time that it saves you by seeing maybe another client. So the first platform is the MHS platform. So it's called the MHS Online Assessment Center. You can create an account there if you like. You can kind of get more information by clicking on this link that I have added to the slides. What it allows you to do is you create a client profile in this assessment center. So you enter client name, date of birth, their gender, and that's basically it. And then you can say, I want to administer, for example, the cars for this person. So you say, I want to send a link via email to this person. You generate a link in this online platform, and then you can either send them an email through the platform, or you send an email using your own email kind of software. And what clients do, they just click on that link. It takes them to a secure online platform where they're presented with the questions that are part of the CARS questionnaire in this example. They fill out all the questions, they click submit, and then this automatically gets sent back to the online assessment center. You get a notification that they've completed the questionnaire, and then you can choose to have that questionnaire scored in the assessment center. I think it's really great. Like I said, there is a fee associated with scoring the reports, but they're quite good. They're quite detailed, and it saves you just a lot of time, especially if you do a lot of ADHD assessments. Another example of such a platform is the WPS Pearson platform. So again, the link is in the slides. Just explore that a little bit. Very similar logic. You create a client profile, and then you can online create links that you can send to your clients. They again complete these questionnaires online, and the platform can score the questionnaire results for you and generate a questionnaire report. The last one is the Q Global platform. So again, a Pearson platform. Very similar functionality again. The reason why I'm showing you 3 of them rather than just one is that it gives you a choice, but also that not all of the platforms have all of the questionnaires that you might want to access. So for example, I used this Pearson platform to administer the ABAS, but they don't have the CARS, for example. So I used the MHS Online Assessment Center to administer the CARS, that adult ADHD assessment. Okay, are there any questions about that so far before we jump into just a very brief discussion of assessment report writing? Okay, so question is, so imagine it was a young child that's your client, right? You would meet with the parents, carers, and do a semi-structured interview. Then the questionnaires and the strengths-based measures would be completed. What would you do with the actual child? Which is a great question, like especially with young children, right? So with older children, I would always recommend have them there at the intake interview, because you also want to hear about their perspective, right? So what do they find difficult, etc. I would probably recommend doing that with a 6-year-old as well, but it depends a bit on the setup of your office space. So I have kind of enough space in my office here and enough kind of toys around for the child to be able to entertain themselves while you're chatting to the parents. If you kind of don't want the child to hear some of the things that you're discussing with the parent because maybe they're a bit explicit, I would schedule another brief meeting so that I could at least observe the child. So I wouldn't I wouldn't provide diagnosis without actually having seen the child. So in that case, I would arrange a standard intake session, semi-structured interview with the parents, send them the questionnaires that they can complete in their own time, and then schedule another short session to meet with the parents and the child, or one of the parents and the child, and kind of go through some questions with the child in a way that's doable and that's positive for them. Yeah, that's a good question, though. So question is, do I use anything structured for those discussions with the child? I do and I don't. So I use a lot of questions from those structured interviews that I showed you earlier, right? But I don't administer the actual structured interview to the child. So when I have a session with a child, it's always much more free-flowing. That's not an absolute requirement, but that's just my preference. I want them to feel comfortable, and I want it to be a positive experience for them. And often they get a lot more anxious if it's a very structured setting. So I often start off with just chatting a bit about some things they like to do. Just gives you a bit more freedom. I don't observe in schools often anymore. I did do that a lot more earlier in my career. It's just, it takes up a lot of time to go to school observations, and there's a lot of driving time involved. So it kind of increases the costs as well for parents. It's not a kind of a must based on the best practice guidelines to observe the child in the school setting, but we do need to get input about how the child functions in the school setting. So we do need to query that teacher perspective. You definitely can do a school observation, and that might give you some strengths as well for the child. But I think it would be important to have that discussion with the parents and with the clients, right? So do they want you to do a school observation? If they want that, what is the things that they want to get out of this? And I would also communicate clearly to them that it's not a requirement for an ADHD assessment to do a school observation. But that doesn't mean that you would never do it, right? But I think have a very transparent conversation with the parents in that example about it. And I do a similar thing with when I think it would be beneficial to do a cognitive assessment as part of an ADHD assessment, for example. I very openly discuss with people, look, this is not part of the best practice guidelines, right? We don't have to do this. It will add an extra cost to your assessment. But I think it might also give us some additional information that might be very useful. So I think always give people that option, right? Search for that informed consent. Okay, the report writing section, I'll keep it very short given the time that we have. I have included some resources here that are pretty good, especially the Schneider et al. 2018 Essentials of Assessment Report Writing is really very handy for kind of if you want to dive into that assessment report writing. This is the book. It's quite a thick book. You don't have to read all of it, but it's a handy resource to have. I think some kind of take-home messages in terms of writing an assessment report is think carefully about who your audience is. So who are you writing for? Often it will be the client that you're writing for, as well as other mental health or health professionals, right? So if you diagnose someone with ADHD, you always want to give them the option to take that report to a psychiatrist or take that report to a pediatrician if they want to explore medication, for example. So often you need to write a report with having this dual audience in mind, right? you want to often kind of keep your goal very clearly in mind as well. So is that communicating the diagnosis? Is it asking for school support? Is it pointing out what an individual's strengths and limitations are? Is it mainly focusing on future recommendations? Or is it a report for a funding body, for example? So all those things matter in how you write a report. So just a couple of questions to ask yourself when you're sitting down and kind of starting to write a report. I often deal with this dual audience, so having the client as an audience and having other mental health professionals as an audience as well by having an appendix. So I often include an appendix to the assessment report where I provide more detailed information about the questionnaire results, for example, or about the cognitive assessment, if I did a cognitive assessment. But in the main text of the report, I don't so much present the actual results, but I talk more about what do they mean, right? Does it mean that someone shows higher levels of hyperactivity and impulsivity, but shows normal range, a kind of expected range levels for inattention, rather than saying, oh, the T score for this particular subscale was, I don't know, 75. So what you want to do is you really want to make it understandable to your audience, whatever it is that you want to communicate, right? So you want to go, I think this picture is quite good. You want to kind of in a way organize this jumble of information that's in people's head and kind of make it into a nice, orderly flow of information. So don't write more complex than is needed. Often we feel, and this applies to me as well, that we feel we need to use a certain kind of complex language or sentence structure in reports. But I think generally speaking, kind of simple is better. Explain what results mean. So don't kind of hit people around the ears with T scores and scores like that. You can mention them, but kind of focus more on what does the result mean? What does it tell us, right? Explain what tests assess for. So don't just say, oh, we did the WISC, but kind of include a sentence that says, oh, we assessed for cognitive ability and the individual profile of strengths and limitations in the cognitive domain. Keep it short and concise. If it's longer, it often pays off to have a short kind of plain language summary at the beginning of your report. Again, I'll include an example of a report as well with the assessment, the best practice assessment kind of guide, not guideline, kind of template that I will send you. One thing I think that's important is to make sure that in the writing of our reports, we also focus on being strengths inclusive, right? So rather than using a questionnaire like the Connor CBRS to only highlight those things that the client is struggling with, can we use it also to include some information to say, oh, actually, they're doing really well in all these other areas. So just kind of think about that strengths inclusive approach as well when you write a report. One thing that's quite important is have actionable recommendations. So often what people say, especially people with ADHD, is that they're very happy to have the report, to have the assessment done. It helps them make sense of things. But then once they get home, they feel quite confused about what's the next step? What do I do now, right? How do I kind of continue on this journey? So making sure that you have a section with recommendations and making those recommendations quite specific. Like, for example, consider whether you want to consult a pediatrician or a psychiatrist for discussion about potential trial of medication. Go have a look if you want to at some of these websites that give us more information about the presentation of ADHD in girls and women, things like that. So recommendations following an ADHD assessment. We've already been over this, but just to highlight it again, make sure you provide some contact details of support groups, websites, etc. Refer for medication discussion, generally speaking, if there is the specifier of moderate or severe. Doesn't mean you can't do it if it's mild, but that's kind of the guideline. And refer for psychological supports if mild, because then it's often the first step, or severe, in which cases often medication support as well as psychological support is recommended. So question is, do you show clients results after they complete each assessment, or you give them the results and report after they complete all the assessments all together? So what I do is I talk with them about it at the end of the process. So I have one feedback session where I show them what has come out of the questionnaires, but I also present that overall report to them. So I don't discuss with them each individual questionnaire result once they complete it. I think it works really well to just do that in one go at the end during that feedback session, because I think you run the risk if you discuss each individual questionnaire at different points in time with clients that your message might get a bit confusing, because sometimes it's possible that one questionnaire shows one result while the other questionnaire shows a slightly different result. So if you kind of discuss them all in one go, you can make sense of that. But if you kind of discuss them one after the other as they are completed, I think it doesn't help having a kind of a concise message. So I would recommend discussing them at the end all together. The SAFE, yeah. So someone asks, I'm due to start with a clinic that uses the CEFI. I don't use it that often, but it's quite a good tool. So it looks more at kind of executive functioning. Yeah, so definitely sensible to use. Yeah. So somebody asks, how many sessions does it usually take for a complete assessment? Yeah, that's a very important question as well. So generally speaking, my assessments for ADHD on average take 3 sessions. So there's that intake session with the structured interview. Then there is the feedback session where we talk about what do we find in terms of a diagnosis, in terms of strengths, limitations, and in terms of recommendations. And then there is one session in the middle that will often in my practice be used for doing a cognitive assessment, or for doing an observation with a child, for example, in session, or kind of having those kind of more interactive discussions with children as well. So I think it's fair to think about 3 sessions on average. Can be longer if you want to do a full cognitive assessment, for example. You can also manage to do it in 2 sessions. So you have that intake session, then you send them the questionnaires to complete at home, and then you have the feedback session. That's sufficient from a best practice assessment perspective. So anything, I would say, ranging from 2 to 4 sessions is perfectly sensible. So another question is, are there any aspects of giftedness that overlap with symptoms or strengths of ADHD? It's a really good question. I might have to get back to you on that one. Because there are a couple of recent articles that look at that kind of at least cover that area that I haven't read in detail yet. Generally speaking, symptoms of ADHD or ADHD-like behaviors, it is important to rule out giftedness, because you can kind of imagine that a child that would show a very high cognitive ability might show some of those ADHD behaviors, right? Kind of not paying attention, maybe talking to classmates, etc. But not because of ADHD, but because they've already completed the task in their mind, right? They have already understood it. They have already wrapped their head around it. So as a kind of alternative explanation for ADHD, I think it's important to consider giftedness. Yeah. But I'm more than happy to chat about that more afterwards, or send you some additional resources for that as well. Okay, so very briefly, research shows that medication is most effective in treating ADHD. And people, as we already kind of established, will need to see a psychiatrist or a pediatrician to get prescribed medication. Non-medication supports can be psychological support, so especially CBT, cognitive behavioral therapy, and parent training or support, as well as coaching, are identified as potentially helpful. Some other things that are mentioned in the best practice guidelines are things like some diet modification, some exercise effects, and environmental changes. None of these things so far have received very, very strong evidence. So there's still a lot of work that needs to be done in this area to find out more about what are the most optimal non-medication supports for ADHD. Environmental adjustments can be quite powerful. So these can be things like separate seating for exams for high school students, preferential seating in the classroom or at work, having more time for assignments, being able to apply for extensions in university more easily, allowing people to use fidgets, having regular movement breaks, etc., etc. So the last thing that I want to touch on briefly is ADHD assessment in women and girls. And I think this is something that's really quite important, as ADHD is still really underdiagnosed and under-researched in women and girls. So most research has focused on and has been conducted with boys. Many girls and women go undiagnosed currently, or they are only diagnosed once they have reached adulthood, because their presentation is often a bit different from that in boys. So there seems to be recognition and referral bias in females. So people are less likely, so health professionals and teachers or parents or even people themselves are less likely to identify certain difficulties they experience as ADHD related, because it's often thought about as more of a boy's condition. Another thing that we see is that females with ADHD much more often present with the inattentive presentation of ADHD as compared to the hyperactive, impulsive presentation. So that doesn't help diagnosis either, because that is more challenging to diagnose. Yeah, there's some more detailed information about that here on this slide. There's again some reading again. So these are quite interesting articles on why it's important to really have an awareness of this underdiagnosis of girls. It's really kind of a call to action, to be kind of a bit more perceptive, a bit more sensitive in a way, when we have women or girls presenting to us, to not just say, oh, I think you meet criteria for low mood, or you meet criteria for an anxiety condition, but really to explore in detail whether they don't also meet criteria for ADHD, especially that inattentive variety. Women and girls show more co-occurring internalizing issues, so they more often show high levels of anxiety, lower mood, etc., while boys often show more externalizing issues, again, making it a bit easier at first glance to identify kind of difficulties in boys. As a result of women going undiagnosed for longer periods of time, they often have a stronger negative impact of ADHD on their self-esteem, etc. So often for quite extended periods of time, they live with these difficulties without having an adequate explanation for it, which then makes them conclude there must be something that I'm not doing well enough, etc. Really have a look at, if you're interested in this, also if you're not so interested, because I think it's important, at these two articles. They're really quite good. They're also pretty easy to read. So conclusions and take-home messages is really that it's really important to follow the recent best practice guidelines. So have an intake interview, have questionnaire measures from multiple informants. Also important to think about whether you can make your assessment strengths inclusive, neurodiversity-affirming. That will require a little bit more creativity because it's less researched so far. There are less questionnaires that are commonly used that we would have to reach for to do that. So it might be sensible to start with kind of set up your best practice assessment following the guidelines, and then think about what can I add to this to make it strengths inclusive, to make it neurodiversity affirming. And I guess the other thing that's really important is that ADHD is very heterogeneous. So presents differently in girls and women, presents differently sometimes in minorities, can look very different over the life course or after certain transitions. And individual strengths and limitation profiles can look very different for different people. I really want to thank you guys for signing up for today's webinar. I really enjoyed preparing it. I really enjoy any chance I get to talk about ADHD assessments, really a passion for me. If you have any questions following the webinar, just contact me on admin@joycevromen.com. You can also check out any of those social media or our website, etc. Like I already mentioned a bit earlier on in response to a question, I'm more than happy to, if you need any input on your ADHD assessment process, or if you want any supervision for a particular assessment case, more than happy for you to contact me. Or also more than happy to further discuss anything ADHD assessment related, basically. I'm just being mindful of the time. If there are any questions at the moment, maybe we can have another few minutes, maybe 5 minutes or so for questions. Yeah, good question. So another question is, there's no observational tool like the ADOS for autism for ADHD. That's correct. There's no equivalent to the Autism Diagnostic Observation Schedule for ADHD. Yeah, so we don't have that. There are some other things that you could consider including as well. So you could consider including neuropsychological assessment for ADHD. So these are, generally speaking, computerized tasks, like, for example, the TOVA, the test of variables of attention, they are a little bit kind of akin to an observation in session of someone's attentional behaviors. If you look at the best practice guidelines, it's not necessary to do this neuropsychological assessment because it doesn't add to the reliability of the diagnosis. But if you use it to get more information about a person's individual strengths and limitations in their attentional profile, it can be useful as an additional measure. Yes, so someone asks whether small group supervision would be an option. Yes, that would definitely be an option. I'm more than open to kind of arranging that or having a discussion about that. Somebody else asks, the clinic I will work at uses the TOVA. Do you offer training on that? Yes, I do as well. I do quite regularly use the TOVA as well in my assessments. And yeah, we can definitely arrange a time to do some training on that as well. More than happy to. Great. If there are no more questions, I'll say bye to you guys. Thank you again for sitting through this on your free Saturday morning/afternoon. Really appreciate it. And yeah, please reach out if there's anything else that I can help with or any questions that pop up after the webinar. See you guys. Thank you.